During coffee breaks on Friday, I heard people talking about the talks. Most people were curious about what they heard. Some were fascinated with the approaches presented, drawn to them, almost as if they want to convert into either DBT or TFP. Others had negative reaction and could not identify either with the concepts or with the technique. I was really pleased to hear all of these reactions. That we want to encourage dialogue between different approaches and to promote I think I hear voices. Okay. You know, many psychotherapy books don't fully show us how it really works. And most of us never see other therapists work as we work behind closed doors. So this is why in planning the conference, we chose to include live demonstration of therapy session in order to demonstrate how leading figures in each approach would try to treat a person suffering from borderline personality disorder. And today our patient will be the actress Asti Zkehיים. It is not easy to be attuned to another person in the intimacy of 700 people. So I really want to thank all the participants, Professor Peter Fonagy, Professor Ellen Frozetti, and Professor Frank Yeomans. I would also like to thank Dr. Rifat Cohen, Dr. Ilan Diamant, and Mr. Yoav Broshi, and Asti Zkehיים. We all try to build a character that will allow all of us to better understand what really works in the treatment of BPD. And I would like to call now Ilan Diamant to introduce Professor Peter Fonagy. Ilan has done his PhD thesis under the supervision of Peter a few minutes ago or years ago. Ilan?
I'm delighted and excited to welcome and present Professor Peter Fonagy, my former supervisor and tutor, who kindly accepted my request to participate in our conference, albeit his tight schedule. I wish to illustrate Professor Fonagy's profound contribution to our clinical knowledge and capacity to treat borderline patients with just one short vignette taken from the research I conducted as a PhD student almost 20 years ago under Peter's supervision. So this was the first study group to be treated with MBT. The patient was severely and repeatedly physically and sexually abused by her adopting father between the ages of 5 to 12. In one of our last meetings, I asked her whether she knew the abuse had really happened. And she replied, "Am I saying what really happened? I'm not sure that I am. Or I may be exaggerating to make sure you understand. Because you weren't there every day. So if I tell you one little thing, you might think it was nothing. So I have to make sure you understand." Peter Fonagy's brilliant contribution to my understanding was that she had to make the other person believe in order to know herself what the truth was. She probably thought that if the other believed something, it must be true, and then she could believe it too. By seeing the other believing her, she comes to believe herself. Along these lines, Professor Fonagy used the Descartes statement, "I think, therefore I am," to introduce the concept that mother thinks, therefore I am. One of the fundamental building blocks of MBT that will be introduced this morning. Now, Professor Peter Fonagy is a national clinical lead of children and young people's improving access to psychological therapies, and director of UCL Partners Mental Health and Wellbeing Program. He is Freud Memorial Professor of Psychoanalysis and head of the Research Department of Clinical Education and Health Psychology at University College London, Chief Executive of the Anna Freud Center, London, and consultant to the Child and Family Program at the Manning Department of Psychiatry and Behavioral Sciences at the Baylor College of Medicine. He's a senior investigator for the National Institute of Health Research and holds professorships at both Harvard and Yale. He's a clinical psychologist and a training and supervising analyst in the British Psychoanalytical Society in child and adult analysis. A major focus of Professor Fonagy's research have been an innovative research-based dynamic therapeutic approach called mentalization-based therapy, which was developed in collaboration with a number of clinical sites, both in the UK and in the US. Professor Fonagy is also engaged in major collaborative programs exploring developmental psychology, psychopathology from an attachment mentalization perspective. Another thread of his work involves UK research collaborations, concerns with the effectiveness of psychosocial treatments, and he has published over 400 papers and has authored or edited 17 books. Professor Fonagy has been appointed an officer of the British Empire, OBE, in Hebrew. פרופסור פונגי קיבל תואר אבירות מהמלכה on the Queen Elizabeth birthday last June for his services to psychoanalysis and clinical psychology. As far as I know, Peter, you are the first psychoanalyst in the UK that has been awarded an OBE. So, without further ado, please, Peter, tell us what works for BPD.
Doesn't want fit. Okay, I'm absolutely delighted to be here, and I'm delighted that Ilan invited me, and I'm always very pleased to come to Israel whenever I can, and I'm asked, I will. So it's a very special thing for me to be here, and I appreciate all of you being here. Mentalization, I'm going to talk about that briefly and without too much technical details. The NAEPD conferences are usually ones attended by a very broad range of participants, and I tried to do something that I don't normally do, and when I give talks, is to be comprehensible. The other thing is that when I get excited, I start talking faster. And I know that your first language is not English for the most part, so if I start talking faster, you won't understand what I'm saying. So I don't know what to do about that. The other thing is when I get anxious, I start talking faster. But I don't know what to do about that either. But whatever you do, don't make me anxious, okay? So, mentalization. These are some of the guys who have written the talk I'm about to give. I don't have time to go through them, but I want to identify that particular chap, Anthony Bateman, and George Gergely. And most of the ideas I'm going to discuss today have been developed with them. They're not my own. These are some American colleagues who have worked with us on MBT, and these are some European colleagues, and it's a longer list of people whose photographs I do not have. And there's Ilan. There you are on the list, so they can feel good too. This is the most recent offering on MBT, and it's kind of fairly recently released, and it's new and improved, and it washes brains whiter, and it's longer than all previous versions. These books have been getting longer and longer. It's not a good trend, so we are trying to make the next one very short. Anyway, so I'm not going to talk about this for long, but this is just to show that hedgehogs, chimpanzees, and humans are slightly different in numerous ways, but hedgehogs there can only cope with about 4 other little hedgehogs being around them. Chimpanzees can cope with about 25, 35, that sort of range of other chimpanzees. Human beings, I mean, that's a big city, millions. And what accounts for that really is bits of the brain that have developed in order for us to be able to be together, to be social beings. Even very clever non-human primates are unable to identify when something is done intentionally or when something is done because of serendipity. So if I was to kind of drop this thing, but catch it, but I can't do it because I'm holding the mic, but do a kind of, you know that this hasn't slipped out of my hand, but it's something that I'm trying to do to demonstrate a point. And you don't have to think about that. You immediately know, you immediately compute what my intention could have been. And this is your capacity to mentalize, and my capacity to mentalize. But when this capacity evolved, all kinds of good things came with it. One was self-awareness, because in order to understand someone else, one usually emulates that mind in one's own mind. What could have made that person do whatever they did? And in that process, we developed self-consciousness. And that brought with it things like embarrassment and shame and guilt, of which, you know, a fair amount exists even in this room, I hazard to guess. You know, if you think about, just for a moment, the most embarrassing thing that has ever happened to you, just for a moment. I'm not going to tell you what my most embarrassing thing is. I'm going to ask Ilan to tell me that. The most embarrassing thing, it is because of what other people we imagine what other people had thought of us in that situation. So it involves mentalizing, not to the good. But it also is a way that we can get beyond our body, our physical reality, and acquire spirituality, which is a part of mentalizing. And it's also a hint about how our sense of self is generated through a social process, about which I'm going to say a great deal more later. Mentalizing is, we define it in a not a particularly original way, as an imaginative mental activity, perceiving, interpreting our behavior in terms of intentional mental states, intentional in Brentano's sense of the term intentional, needs, feelings, wishes, beliefs, desires. And to put it kind of more simply, it's things like seeing ourselves from the outside and others from the inside, or understanding misunderstanding. I mean, I don't know, those of you who are psychotherapists would have discovered that you make an enormous, if you have some kind of road, you know, these things happen. You have a major misunderstanding with your patient. You have a bit of a car crash with your patient, and you have a major misunderstanding. That actually then leads to often enormous progress that follows it. Because in order to understand that misunderstanding, you really have to try and get into each other's minds and try and see where you came from. But having mind in mind, being mind-minded, being mindful of minds, mindfulness really is in many ways a particular form of mentalizing, and we'll be talking about that in a minute. But the way we connect ourselves in the past, our present, our future, it's through the mental states that we remember having in the past is our past. And when we project ourselves into the future, we very rarely project ourselves. I'm thinking about myself, what I will be at 80. I probably wouldn't want to think of myself what I will look like as 80. It's bad enough what I look like at 60, you know. I don't want to project myself physically, I project my mental state. So what connects past, present, and future is mentalizing. Now, the reason that's so important to us clinically is because when a person loses the capacity to mentalize, they also lose their continuity of selfhood. So the person who was them 2 weeks ago is not them now. You know, I'm sure you've all had patients who, with this diagnosis, who 2 weeks ago came in and said, "You are the most, without you, I would be dead now. You had saved my life. You are the most wonderful therapist that I could have had. I am so lucky. I'm such a lucky person. I count my lucky stars every night." And you say to yourself, no, this is idealization. Surely, no. You exaggerate. But you really, you like it. Anyway, but then 2 weeks later, the person comes in and threatens to sue you and says, you know what you've done, this is worthless. I've been coming here for 6 months and nothing has changed. What are you doing? And you talk this nonsense. I don't understand what you say from one session to the next. It's absolute garbage. What you say, it's sham. And you think to yourself, but what happened to this person 2 weeks ago, you know? And you want to remind them, don't you remember 2 weeks ago I was this wonderful human being and who you really always wanted to be with and wanted to marry and all kinds of things. Whatever. But actually, when you've lost that capacity to represent your own mental states, that person has disappeared. It's just you can't connect to it. And most importantly, seeing oneself as agentive, seeing oneself as an agentive being, somebody who acts because of their own volition, because of a mental state that actually drives that action, is enormously important in feeling oneself to be a person, not to feel empty, not to be a shell, but to be someone, because I can decide that what I want to do is to lift my arm up. That's a bit of a stupid example. And it's really all about creating a phenomenological coherence. Now look, mentalizing is not a new concept. It's actually a particularly unattractive word for something that has been known for a long time. And Choi Kane and Gunderson, Lois Choi Kane and John Gunderson, suggested a number of related concepts, such as psychological mindedness, which is very cognitive, and affect consciousness, which is very emotion-oriented, or mindfulness and empathy, but empathy is usually about others, and mindfulness is usually mental states focusing on the self. Broadly, there are, and as you see, an emotion-oriented part, and there is also a cognition-oriented part to mentalizing. But what we are concerned about here today is really that the areas where those things overlap, when they work together, because we are not aware really of these things working separately as we interact. It all becomes one process, and we call that mentalization. Okay, so let me talk a little bit about the brain. This is not going to be of any import, and those of you that want to stop listening, this is the time to stop listening. This is the brain, and there are a bunch of areas like the medial prefrontal cortex, the temporoparietal junction, posterior superior temporal sulcus, the amygdala, anterior cingulate cortex, anterior insula, inferior frontal gyrus, interparietal sulcus. All these are involved, these areas are involved in mentalizing. To simplify things, I would say that there are two key components, two types of mentalizing. There is emotional mentalizing, which is the capacity to experience affective reactions to the observed experiences of others. And cognitive mentalizing, which is much more to do with the role-taking ability, the capacity to engage in some kind of cognitive process, adopting another psychological point of view. But also, it involves making inferences about others' emotional states. So emotions come in two lots. One is experiencing others' emotions, and the other is making inferences about them. And these are somewhat independent capacities. If you want to see that again in a very simplified way, there are a range of basic mechanisms represented by different parts of the brain, a part of the brain that simulates others, that indicates self-pain, self-other relationships, and autobiographical memory. And these add up to a number of processes that include emotional contagion, emotion recognition, shared pain with others, affective mentalizing, cognitive mentalizing, that generate a response of emotional empathy or cognitive empathy. And mentalizing is really the amalgam of all these. And that's something that's really quite important for us to remember. I would also want to, at this point, make it a little bit more complicated, but also, I hope, a bit edifying. So, because that looks like a big lump there, we have started thinking about it as being made up of a number of dimensions. And in terms of thinking about borderline personality disorder, this is actually quite important to understand. So for those of you who switched off when you heard the word brain, can you come back to me at this point? Thank you. Because this is clinically kind of important. So what you see here are 4 dimensions. Explicit, controlled, conscious, reflective thinking, and automatic, non-conscious, immediate reaction. So most of mentalizing actually is non-conscious and is immediate. But in order to mentalize properly, we have to be somewhere in the middle and balance those capacities. So not to react immediately to things, but then stop, press the pause button and think about it a little bit. And indeed, there are different bits of the brain that correspond to that. And this is reasonably well accepted. That's very obvious. You might have not thought so much about another dichotomy, but it's very important when we try to understand borderline personality disorder. And the dichotomy is between trying to understand someone's mental state in terms of their physical actions, their reaction, their facial expression, for example, and the type of mentalizing that depends on going inside and trying to understand what they might be thinking, figuring it out, what they might be thinking in this situation. And again, there are different parts of the brain that relate to this, but it's in the middle that this is, we have to balance the two. Going back to the dichotomy between emotion and cognition, these two ways of thinking are actually not only represented by different parts of the brain or subserved by different parts of the brain, they actually have different propositional logic. Whereas cognition has the propositional logic of a self or an agent attitude proposition, which is the fact that I'm thinking something. If I say, I'm thinking that Ilan had breakfast this morning. I think that Ilan had breakfast this morning. Ilan may or may not have had breakfast because the reality of Ilan having breakfast or not is totally independent. My thought is still true whether he had breakfast or not. That's an agent attitude proposition. So cognition divides reality from experience. The same can't be said of emotion. If I said something like, I'm pleased that you are in pain, that doesn't sound right. And it doesn't sound right because it starts from the self. I wouldn't be pleased to be in pain. So the self-affect state proposition that underpins emotional attributions depends on feeling something oneself and then from that assuming that the other person is feeling something similar. But if I feel it, then it's true because it starts from the self. So as you'll see, the problem starts when that logic starts being applied to cognitions. And we'll see in a minute why that creates a lot of problems for individuals. And finally, I'd like to talk briefly about the self-other dichotomy. There are two brain systems that underpin self-other distinction or awareness of others and the self. Again, they have to be balanced. One is very imitative. So these mirror neurons that you might have heard about, that people, by observing an action, somebody performing an action, they actually are immediately inclined to perform the same action. They have what psychoanalysts used to call primary identification with that person. The extent to which that is suspended depends on the activation of another part of the brain that inhibits that kind of immediate identification. So when my son plays rugby, and when I watch him, and I like watching him play rugby, and he's a big chap, but when I see somebody who's bigger than him really going very fast at him, I cringe like that. That's primary. Now, what stops me from running onto the pitch and beating the guy up is that actually I can reflect. I have this explicit conscious reflective awareness. So I'm actually prevented from doing that. Now, let me put a bit of flesh on the bone here. Where do patients with borderline personality disorder fit in? So patients with borderline personality disorder are at the implicit, automatic, non-conscious, immediate end of that dichotomy. And because of that, what we notice about them is that they often are impulsive, they make quick assumptions about others, about their feelings. These are not reflected on or tested. They're very quick to come to a conclusion. But when they think about thoughts and feelings, when they try and reflect, it doesn't have that sense of genuineness about it because it's disconnected from a physical experience of themselves. And it's kind of pseudo and very suggestible. We call it hypermentalizing or pseudo-mentalizing, and it's very dangerous clinically because it's very easy to persuade a person with this diagnosis that your model of their mind is the accurate model. What they find hard is interpersonal situations where they actually would need to explicitly, in a controlled way, reflect on somebody's mental state. So they get into trouble interpersonally because they misinterpret often others' feelings. Now, in terms of the exterior-interior dichotomy, they err on the side of being exterior cue-focused. And that leaves them being hypervigilant and actually also quite sensitive about the physical appearance of people around them. So their sense of what if you do something, I need both hands for this. If you say during a session, you just look at your watch, it leads to a terrible problem because they immediately say, "You're bored with me." I say, no, I was just seeing how much time we had together. Still, now you're bored with me and you're lying. I saw you looking at your watch. So, but on a positive side, I have patients come and say, "You look tired." And I think, do I? Are you upset about something, or are you worried about something? And I am worried about something, and they seem to know it better than certainly my wife. And I'll leave it at that. Anyway, so that's because their mentalizing is out of balance, and it's more concerned with things going on outside than inside. But it also leaves them very poor with interior cue-focused mentalizing. So they do not have a conviction about their own ideas. They constantly seek external reassurance about their own thoughts and feelings. They have an overwhelming sense of emptiness because they don't read their own mind. And they seek intense physical experiences to overcome that, to make themselves feel real. In terms of that polarity between emotion and cognition, it is cognition that they have difficulty with, and affect is what they use. And as a consequence, what you find is what you find is overwhelming dysregulated emotions, because cognition is not there to perform what regulation would be needed. Also, it's felt something that is dominating everything else, dominates all directions, and in order to come to any kind of understanding of a person with this diagnosis, you have to understand how compelling their feelings are. They're not like our feelings that are always balanced by cognition. They're immediate because they do not have a context, and they lead to catastrophizing because that feeling, without its thought context, feels like a disaster, a terrible disaster. And empathizing with that and bearing that in mind is very important. But also, that leaves them, because they use the logic of emotion for cognition, leaves them with an unnatural certainty about ideas. They know how it is. And anything that they think is real. It's impossible to see things in a different way. And finally, on this dichotomy of being a self with others as opposed to a self thinking about others, what you see is a vulnerability, a deep and profound vulnerability that I just want you to, for a moment, think about. Because what would you feel? How would you if you do not have the capacity to inhibit the impact that others have on you? That their feelings, you resonate with their feelings. Their feelings become your feelings. And if you're too close to them, actually what you feel is you disappear, unless they are totally focused on you. If they do anything for themselves, then you're no longer there. As a consequence, sometimes we find people with this diagnosis being very rigid in asserting themselves, to try and show where the boundaries are, and control others, apparently, and control their thoughts and feelings. And we call them manipulative, which is not a nice term, really. But they're not being manipulative. All that they are trying to do is stopping you from impinging on them, which is a very reasonable thing to want to do. So we have summarized this in a very simple model. And I'm just going to go that the three kind of phenomena that you come across. One is psychic equivalence, where this is when the external world and the internal world feel exactly the same, have the same significance. You have no tolerance of alternative perspectives. And it reflects the domination of the self-affect state propositional logic, and coupled with a very limited capacity to focus internally on mental states. The other thing that we come across is what we call pretend mode. Pretend mode is when ideas form no bridge between inner and outer reality. Words are easy, and you find yourself thinking things at a pace, much greater pace than normal, but also be very suggestible, that you can change very dramatically from one line of thinking to another. You become what we have called hypermentalizing or pseudo-mentalizing. You develop overly elaborate models of other people's mental states. And at extreme, you dissociate, you just switch off, you switch out and turn completely inward. And what it reflects, as I've said, is the domination of an implicit, inadequate internal focus and very poor belief, desire, reasoning, and vulnerability to fusion with others. Finally, the teleological stance, and this is the one that impinges on us most. The focus is on understanding actions in terms of physical as opposed to mental constraints, because it's only what I can see, it's only what's on outside, it's only what's in external, because of the extreme external focus, it's only that is visible that I actually believe in. So the only way that I feel loved is if somebody holds me or makes love to me. Otherwise, somebody just being affectionate in the way that people do by being mentalizing of them doesn't mean anything. And linked to that is something that we've called the misuse of mentalizing. And the misuse of mentalizing is when you have a teleological experience of the world, that only what you can have physical evidence of that matters. But you also have an uncanny capacity to know other people's minds through a process of not feeling for them. And that allows you actually to be able to get inside them in a funny way, as you do in certain constellations like antisocial personality disorder. And I just want to show you an illustration of this.
You know, I just couldn't stop thinking about it.
Yeah.
So, yeah. So, you know, I went to the fridge and I opened up the meat drawer. You know what the meat drawer is, right?
Yeah. What was in there?
Well, I'll tell you what was in there. You know that bacon that's like maple? It's got maple flavor.
The maple kind, yeah.
Yeah, so
Yeah.
I took that out and I thought,
Yeah.
I know who would like that. Me. So I ate it.
Oh, no. You're kidding me.
Nope. Not kidding. You know, I also noticed there was some beef in there. Yeah, you know, steak, you know, juicy. Well, I ate that too. But I went back to the fridge just a few minutes ago and I put something together really special. You're going to love this one. I took some chicken.
Yeah.
I put some cheese on it. Then I covered it with...
Covered it with what?
I covered it with cat treats.
Yeah.
Then guess what?
What?
I gave it to the cat.
Okay. So that's the misuse of mentalizing. I'm sure that you have come across people like that. Anyway, so let me now come to attachment briefly. Now, you can measure mentalizing. It's a very simple measure of mentalizing that I'm sure many of you know, Simon Baron-Cohen's. You can tell, I'm sure, because you're mental health professionals, that that's indeed a friendly expression. And this one, surprised, sure about something, joking or happy. Exactly, very good. And this, joking, flustered, desire, or convinced. This is the only one there's a gender difference on. Women immediately see that there's desire. Men do not. There's a problem there. Anyway, this is another problem. This is a personal trauma that I had. That idiot is Robert Greene, 2 World Cups ago, as a goalie in the England-US match, which was the opening match for England, letting a ball in that I could have saved. I mean, it was ridiculous. I could have saved now at 60. Anyway, this is what he looked like. Was he upset, angry, disappointed, or frustrated? Yes, is the answer. Okay. This is what the English fans look like. Now, there's a reason for that, and it's in the brain. Don't have to worry about it, but one thing that I want to draw to your attention is that the parts of the brain that we were talking about earlier, where mentalizing is represented, mentalizing the self and mentalizing the other are overlapping. So what for a large part, thinking about ourselves and thinking about others is the same. This overlap is probably telling us something about the relational aspects of mentalizing and the way we find our mind initially in a mirroring other. We depend on the contingent responses of others to be able to find ourselves, understand ourselves. And we are enormously sensitive to this kind of contingency. And it is something that parents automatically do. They can't stop themselves from mirroring. And this brief video clip, before going to a clip, there is a reason, a mechanism that underpins this. Because when someone is exposed to threat, they feel distressed. That activates the attachment system. That generates proximity seeking. That downregulates affect. And the child bonds to that person who was helping them downregulate affect in that physical proximity. And it creates a bond to that individual. And, you know, that we call that attachment. It's a special kind of relationship, and you don't want to exchange one person for another. So we all have mothers, most of us do, and in fact, all of us do, really. So we have mums, and we wouldn't exchange our mums for another mum. Would you say that was true? Okay, right, we'll leave it at that. But what I want to draw your attention to is what happens when the attachment system is activated, there's proximity seeking, and the consequent emotional experience is adverse. That it leads then to distress and fear that actually activates the attachment system further, leads to further proximity seeking, and generates further adverse emotional experience. So this is when the attachment system becomes disorganized or goes wrong. And there are different categories of attachment, depending on whether you have a positive view of yourself or a negative view of the other, positive view of the other, negative view of the other. In terms, this one way of thinking about it is that someone who sees themselves in a positive way and sees others in a positive way is secure in their attachment. Someone who sees others negatively and themselves positively is dismissing, and someone who sees others positively but themselves negatively, seeks others, is preoccupied. And finally, those who are high in avoidance see others negatively and view themselves negatively, are fearfully avoidant. Which is the worst category to be, no doubt. But the interesting thing is that borderline personality disordered individuals actually belong to all of these categories. Their attachment system as such is disorganized. And this is a major problem because the way that you activate a therapeutic relationship, you activate the attachment system, you actually create trouble for yourself rather than enter into that potential soothing relationships that you might otherwise do. Now, this is the video that shows how important contingent relationships are. That mum is going to stop responding contingently to that baby at one moment. Now she's showing her still face. She's not responding to the child, not responding contingently. Look at the impact on the baby.
másikat is le fogod venni, leveszed azt is, nem kell neked a cipő, nem kell neked a cipő.
So you saw that even though the mother stayed there, because she stopped responding contingently, as far as the baby was concerned, the baby felt that she had disappeared. So we depend on the other in order to discover ourselves. The other must be there to mirror, but the mirroring can't be too accurate, because if the mother responds to the infant's distress by crying, it will not soothe the infant. What the mother needs to be able to do is to mark her mirroring so that it's nearly but clearly not the same as what the infant is expressing. This is an illustration of unmarked mirroring of sadness, and this is an illustration of marked mirroring of sadness. You can see the difference, I'm sure. Anyway, moving rapidly on. So the model that we have is fairly simple, that the constitutional self-state of the infant is mirrored through resonance, reflection, expression, a contingent display of understood affect, creating a representation in the infant's mind of their experience. That symbolic representation becomes a building block of mentalizing. And the physical self then actually acquires a psychological self-representation. And this is the idea that we have been advancing for some time, but not our idea. It actually is originally Hegel's idea, then repeated by Winnicott, that our sense of psychological self is an internalization of the mirroring response of our caregiver. Okay, finally, one thing that's stable and predictable about borderline personality disorder is that it is neither stable nor predictable. Why is that? It's because arousal inhibits controlled mentalization, leading to automatic mentalizing. And I will illustrate this very briefly using a classical author, Shakespeare. So this is from Othello in the first act. Othello is enormously balanced and mentalizing, and his friends are having an argument, and he intervenes and in a very mentalizing way says, Why, how now, who, from whence ariseth this? Are we turned Turks, and to ourselves do that which heaven hath forbid the Ottomites? For Christian shame, put by this barbarous brawl. Anyway, then things happen with Iago, as you can remember, and his love is spurned, and his controlled mentalizing is replaced by automatic implicit mentalizing that's externally focused, and he observes something happening with a handkerchief and then says in the third act, that handkerchief which I so loved and gave thee, thou gavest to Cassio. By heaven, I saw my handkerchief in his hand. And then it doesn't lead to anything very good. But what Shakespeare didn't know was that in the first act, it was left parietal frontal cortex and medial left prefrontal cortex and the medial prefrontal cortex that was active, and with arousal, it was shifted to ventromedial regions and lateral temporal cortex. So, but you could discover things about the brain even before neuroimaging. However, psychological understanding drops when arousal increases, and this is a key concept within MBT. If we are not careful to modulate the patient's arousal, not to overactivate their attachment or any other emotional system, we are likely to place them in a situation where they actually can't cope. Yet as psychotherapists, we often actually find ourselves making the highest demands on their mentalizing capacity at these times. So we demand of them to understand why it is that they are so upset. But it is exactly the thing that they can't do at that point. And it doesn't lead to anywhere good, just like the play. So this is something that characterizes all of us. There is a simple system that switches off, another system that is more posterior and subcortical that switches on at a particular point of arousal stress. And mentalization drops. Mentalization drops at an earlier point. That switch point comes earlier for individuals with borderline personality disorder. That's why we've got to be a little bit more careful. If a person has had adverse emotional experiences and they had experienced distress or fear, they intensify their attachment, as we have seen. They inhibit their mentalizing. They make inaccurate judgments of affects. They become poor at understanding others. They become more intuitive and less reflective. They're more externally focused, more vulnerable to be influenced by other people's moods and so on. And that actually exposes them to further adverse situations. And that's the terrible trap that an individual with borderline personality disorder finds themselves in. So their distress and fear that intensifies their attachment need also inhibits their capacity that normally for us serves to be able to deal with those adverse experiences better. Finally, and I'm grinding to a halt here, what happens to children who are not properly mirrored, not properly reflected? Maybe not because of the parents' inability to do so, maybe because of something genetic in the kid that makes that kid a difficult child, who finds their emotions harder to regulate, and therefore the parents' soothing doesn't work quite so well. But that child still needs to find themselves, even if mirroring had failed. But in the absence of that mirroring, what the child does is what Winnicott described as internalizing the parent into the self as what we have called an alien self. It's a non-contingent non-contingent part of the self that feels like the self, but it is not the self. It doesn't link with other aspects of the self because it comes from outside. It's internalized from outside. And that leads to a discontinuity of self-structure that I think is probably not that unusual. Probably we all have in our own way. But actually, when it's very negative, when negative experiences actually overtake the individual in their life. We all use negative experiences as best we can to identify with the person, to try and take that negativity inside ourselves and try and control it from within. It's called the Stockholm Syndrome, or identifying with the aggressor within psychoanalytic terminology. But if we use this alien part of the self to do that identification, then what we have is an unbearably painful part of ourselves that feels evil and hateful. And that leads to a state that makes you very vulnerable to self-harm. In that state, the best thing that you can do is to find someone else, find another individual who will own that part of you. So if that part of you, that negative part of you, maybe just a very needy part of you, is owned and responded to by someone else, then you become actually addicted, almost, I would say, to that individual. You become totally dependent on them. Even if that person is actually negative, they own a negative part, they attack you. But even then, you want to stay with them because without it, you would lose that part of yourself. So projective identification, as psychoanalysts talk about it, in these individuals is a survival strategy. They will they can only survive if they can do this. This is someone who describes the alien self, a patient of Anthony Bateman's. And I'll just read it for you. If someone was causing you pain or simply tormenting you, perhaps not every day, for the whole day, parts of the day, or for days and weeks on end, you could, if you were brave or desperate enough, defend yourself by perhaps attacking and eliminating your persecutor. But what if this thing you hate was inhabiting your head? You can't exactly say, please leave my body. You can't do anything to get it to just pack up and leave, because technically, physically, it isn't possible. You can say, fuck you, I hate you. You can self-harm with the hugest force your body can withstand, with all you can muster. You can do that. You can be very, very angry and show them who is the boss. You won't stand for it. You won't take it lying down. You won't be heard. You want to be heard. You want to say, right, you think you can hurt me? I'll show you how much I can hurt you. But you and this thing, you are inhabiting one body. You attack this thing and you attack yourself. You don't have a choice, though. That's a sacrifice you make over and over. Eventually you realize that the only way to get rid of this thing, once and for all, is getting rid of yourself. What choice do you really have? No doctor can specify the problem. No medication can fix the problem that can't be specified. You fail to understand yourself. You can't explain to your family or docs. They can't help you because you don't talk. You doubt yourself. Do I even have a problem? People in real life often treat you like you don't have a real problem. They talk to you stupidly. You complain they don't understand. You look a fool. Perhaps that's why you don't talk to them anymore. Maybe you don't have a problem anyway. Anyway, one other way, of course, you can deal with this situation is attacking that person. If you have lodged much of your negativity in that person, you can try and destroy it. And that kind of aggression is also very characteristic of BPD. An externalization of a state of mind and then attacking and trying to destroy it. So this is something that might happen. You have an experience of loss that increases attachment needs, that triggers the attachment system, that triggers a failure of mentalizing, that gets a person into psychic equivalent mode, that actually serves to make that feeling very, very real indeed and intensifies the unbearable experience. To somehow cope with that, you get into pretend mode, you hypermentalize, world becomes empty, meaningless, you maybe even get to the point of dissociating. You then find teleological solutions to this crisis of not having a self. You suicide or you self-harm. So what do we try and do in therapy? And I'll end here. What we try and do is very simple. There's nothing basically to MBT. We try and replace the impression-driven, implicit automatic mentalizing with controlled mentalizing, but so that the balance is restored. We try and make a person who is overly affected by appearance to make more inferences. We try and replace, to some extent, the certainty of emotion with the doubt of cognition. And in relation to emotional sensitivity, we try and generate more autonomy. MBT as a technique is simple. We try and keep it simple. It's focused on affect and focused on the patient's mind, not on their behavior. It's something that is very much in the here and now and uses the therapist's mind as a model to create the space for the patients to find themselves therein. We identify non-mentalizing psych-equivalence, pretend mode, teleological and try and recover mentalizing. The focus is on those breaks and trying to rewind to the moment before the non-mentalizing occurred. We try and explore the emotional context. We identify the therapist's contribution to what might have happened, the therapist's role, because losing mentalizing is probably part of an interpersonal process. It's a failure of the attachment system. And we try and ultimately seek to mentalize the attachment relationship. So in mentalization-based treatment, it's not really up to the therapist to explain to the patient the complexities of their mind. It's not up to me as a therapist to show a person the error of their ways. I am not there to tell the patient how they feel. Any therapy which moves towards knowing how the patient is, how he should behave, how he should think, and why he is the way he is, could, I think, be harmful. So we recommend what we call a not-knowing stance, an inquisitive stance that's there to help recover mentalizing. Is some evidence that what we're doing works. This is our first study, showed follow-up to 8 years that our patients who were treated in mentalization-based day hospital were more likely to be in employment and not have suicide attempts and such like till all the way through the trial. The TAR group remained suicidal. Our patients did well. In an outpatient setting, we showed that in 18 months, we're just doing the follow-up to this study, we were able to reduce episodes of self-harm and hospitalization and suicide attempts. And we were also, this is actually quite interesting, we were able to show that the people who benefited from mentalization-based treatment were those people who had actually more problems, were more severe, structured clinical management, good basic therapy. Thank you. Huh? Okay, that's all right. It's really 5 minutes. Is that all right? Or should I want me to 10? No, it's incredibly generous. Can I come and kiss you? No. But what we're able to show was that individuals who only had borderline personality disorder as a diagnosis did as well in a kind of good clinical management as they did in mentalization-based treatment. But if they had 2 axes 2 diagnoses, they started to be more likely to respond to MBT than good clinical management. And if they had 3 or 4, those that had multiple axes 2 diagnoses got very little out of good clinical management. So it seems that the more impingement, more impediments there is to mentalizing, the more you need an approach that focuses on mentalizing. Otherwise, maybe mentalizing can be recovered. This is a study where we showed that mentalization-based treatment works for adolescents who self-harm, Trudy Rousseau's study. And there are some other studies that take mentalization-based treatment further outside the realm of the borderline situation, the borderline treatment where it was originally born. So we've got a version now that is a family therapy, a mentalization-based family therapy that we find actually incredibly effective in a brief therapy setting, because you can encourage the extent of mentalizing in a family much, much more easily than you can encourage mentalizing an individual. Also, in couples, you wouldn't believe it, but actually some couples don't mentalize well together. It's remarkable, I know. But you can help them, we find. This is a study I'm particularly proud of. It's a cluster randomized trial showing that you can teach a school to mentalize. What's even more important, you can teach teachers to be more mentalizing of the children. Because teachers are actually very poor mentalizers on the whole, or some are. You know, they say, stop it. It's not very mentalizing. But for those in the capsule group, which is creating a peaceful school learning environment, there was a mentalizing intervention. The level of violence dropped if we, and it more happened, more reduction of violence, aggression occurred in those schools, as rated by all the kids in the schools, than if we put a psychiatrist into the school or did nothing. And finally, this is what we are working on at the moment. It's dynamic interpersonal therapy. It's a very powerful combination of an approach that Otto Kernberg's theory, TFP, represents, and a bit of mentalizing thrown in, used with individuals who are depressed. And we are currently, this is a pilot study where we showed that some depressed patients benefited quite a lot from this 16-session therapy. I'm done, more or less. Okay. And even the, this is my last slide. All I was going to say is that what we are working on, other cutting edge, is trying to work with other personality disorders besides borderline personality disorder. So currently our primary focus is antisocial personality disorder, who actually have a different profile of non-mentalizing, whose failure is not so much in cognitive mentalizing, but much more in affective mentalizing. And they do not err so much on the side of implicit and externally focused. That could be read as well, mentalizing. So we are working with this group, and we're just starting a randomized control trial, hopefully to having done a pilot study to treat these individuals. So that's it. I'll grind to a halt. Our next ambition is to deal with narcissistic personality disorder, but of course the balance of mentalizing is far more in the direction of the self and very limited in relation to the other. But we think that in all these cases we can try and modify the therapy so that the absent bits of mentalizing is what we bring to the fore. So thank you.